Today, we're going to talk about miscarriages. This is a very sensitive topic, something that I wish that no one had to experience ever, but unfortunately, it is very common. We see it in our practice all the time, and therefore, we need to talk about it. We get lots of questions on it. So, we are going to do our very best to give you the best up to date information and summarize everything you need to know about miscarriages in terms of diagnosis, symptoms, types, and causes.
And because there is so much to talk about and so much that we want to cover, this is going to be a 2-part series. Even if we don't get to a topic in this particular episode, I promise we're going to cover it in the next episode.
Another term for miscarriage is a spontaneous abortion. And the word abortion is very loaded. Abortion is generally referred to as a selective termination of pregnancy or terminating a pregnancy because somebody doesn't want to be pregnant, which of course can be very triggering to somebody who really wanted to be pregnant and is having a miscarriage. We tend to use the term miscarriage a lot more, but I know in the literature it's also referred to as spontaneous abortion. So we thought it was worth mentioning that the two terms correspond to each other.
A miscarriage, or as we said, a spontaneous abortion, is the loss of the pregnancy before 20 weeks of gestation. After 20 weeks, then it's now called a stillbirth. Now, this 20-week thing, it's kind of arbitrary. To be honest, I'm not really sure why there is this distinction before and after 20 weeks. But it is something that you will definitely hear from healthcare providers and in textbooks and in literature. When we're talking in this episode, we're going to be talking about the loss of a pregnancy before 20 weeks.
Now, miscarriages are extremely common. They're actually more common than is documented in the literature. Many times pregnancies miscarry before it is recognized. The quoted rate of miscarriage in general in the literature is 10 to 20%, but it really depends widely based on age and based on the gestational age of the pregnancy as well. Regardless of the frequency, one miscarriage is too many. I mean, it is a deeply personal experience. We are going to spend some time talking about that. It can be traumatic. It can elicit tremendous amount of grief. It is the loss of a dream. And I think that a lot of times when people have a miscarriage, they are expected to bounce back right away and go back to normal because it wasn't quote unquote a real baby or because it was quote unquote early. But the reality is that the moment that you find out that you're pregnant with a wanted pregnancy, there is a bond that happens. And the loss of that pregnancy or a miscarriage can be quite devastating.
In putting together this episode, I was thinking a lot in terms of the common patient questions that we get. And so one thing that always comes up is, how do I know that I'm having a miscarriage? And so I think it's really important to point out that you may not be aware that you're having a miscarriage. There are many people who will experience a miscarriage that may not have any symptoms, and we're going to talk about that. In people who are having symptoms of a miscarriage, the most common things would be things like bleeding. Oftentimes, the bleeding will progress from light to very heavy. When somebody's having a miscarriage, it can be normal to be soaking a menstrual pad in an hour and that happening for a few hours. A person may also pass blood clots that could be the size of a few centimeters. You may pass some grayish colored tissue as well. Or on the flip side, somebody may have a miscarriage and have no bleeding at all or just spotting. With a miscarriage, if somebody's having symptoms, they may be having menstrual cramps, very severe menstrual cramps, or abdominal pains. But often people do talk about it as being very severe menstrual cramps. Sometimes people will talk about a lower back ache, that it could be anywhere from really mild to quite severe. But again, these symptoms can vary widely depending on a person's experience.
I think it's also important to know that you may have no symptoms at all if you're having a miscarriage. We're going to talk about the concept of a miscarriage later on in this episode, but it is possible to have a miscarriage with no symptoms at all. And at the same time, having symptoms that are typically associated with a miscarriage, like cramps or bleeding, does not necessarily mean that you're having a miscarriage. So that leads me to, how do we actually diagnose a miscarriage? The best way to diagnose a miscarriage is with a combination of blood work and an ultrasound. In an ultrasound, we're looking to see the pregnancy location. Depending on the gestational age, we can determine if the pregnancy has developed enough to determine if it's a viable pregnancy or not. If you had an ultrasound and there was a heartbeat present, and then you do another ultrasound and the heartbeat is no longer present, then there is a clear indication that a miscarriage has happened, regardless of whether or not you're having symptoms. And if the ultrasound was equivocal or there was no ultrasound, sometimes following the beta ECG level, if we see that the beta ECG level is dropping, that is another indication as well that a miscarriage has happened. Beta ECG levels are less reliable because we know that the ECG levels go up and then they peak and then go down slowly. So an ultrasound is the most reliable way of diagnosing a miscarriage.
As part of the diagnosis, the reviewing of symptoms and what the person is experiencing is also really important. We do want to try and figure out, how much bleeding somebody is having. So oftentimes we ask about the number of pads, let's say, that somebody is filling. How much cramping, how much abdominal pain, where the pain is. Is that person experiencing a fever? Because that's a really important thing to find out, because that will change management. Another thing is that we'll often talk about symptoms that could be associated with blood loss. Certainly when somebody is having a miscarriage, there can be very significant blood loss, and some people may have some shortness of breath. They may feel dizzy. Rarely people may be passing out or fainting, and those would be reasons to go to the emergency room. Along with that, and doing the pregnancy hormone levels, we may also take a look at what a person's blood type is to determine if they need management with something called RhoGAM, which we use in patients with certain blood types to prevent alloimmunization, to prevent complications in future pregnancies. And that's another topic that we're going to cover in the next episode.
We just told you that there are no specific symptoms that are associated with a miscarriage, and that you can have no symptoms that have a miscarriage or have a lot of symptoms and not have a miscarriage. And we also told you that it's really important to review the symptoms. But the reason that we are reviewing the symptoms is because that is going to affect our management. It's not so much to diagnose whether a miscarriage happened or not, like how much bleeding doesn't tell us whether a miscarriage happened or not, but it certainly tells us how we should manage this. Do you need to be admitted to hospital? Do you need IV hydration? Do you need a blood transfusion? Do you need to have a DNC as an emergency if, in fact, you had a miscarriage? If you had a fever, that could be an indication of something more serious, like a septic abortion, which we're going to cover later on in the episode. So the reason to review the symptoms is so that we can manage the pregnancy or the miscarriage if that is what is in fact happening.
Along those lines, thing that we maybe don't necessarily ask about is pregnancy-related symptoms. So what I mean by that is that somebody who experiences a decrease in pregnancy symptoms, let's say the fatigue, nausea, vomiting, that is not necessarily a sign of miscarriage or an indication that a miscarriage is going to happen or that it has happened. There are many different reasons out there why somebody may have fluctuations in their pregnancy-associated symptoms, and it is unlikely to be a predictor of miscarriage. Certainly, it's important to be aware of and to be mindful of, but that's not a reason to have an ultrasound done the same day, or it's not an emergency by any stretch. Pregnancy symptoms can fluctuate based on your gestational age. They can fluctuate based on how much you're sleeping, what you ate, or in general how you're feeling. And so they're not very helpful in predicting miscarriage. The next thing we want to talk about is the different terms that we use to describe miscarriages, because they help give us a clue in terms of how that miscarriage has happened, how it's going to progress, and how we need to manage it. Miscarriage is a very big, broad, general term, but we do subdivide in these categories as a way to give a lot of information about what's going on in sort of a short way.
Now we're going to go into the 6 different types of miscarriages.
For instance, the first, we talk about a complete miscarriage. In a complete miscarriage, the body will expel all the pregnancy tissue on its own. Physically, the uterus has emptied. Physically, all the pregnancy tissue has passed on its own without any kind of medical, doctor, medication, surgery intervention. This could be a situation where somebody knows that they are pregnant. They then experience significant bleeding, cramping. They will likely recognize that they're passing some tissue. And then in follow-up, let's say an ultrasound is done and it's found that all the pregnancy tissue has passed. That is a complete miscarriage.
An incomplete miscarriage refers to a miscarriage that after the miscarriage happens and there is a follow-up ultrasound, there is still pregnancy tissue remaining in the uterus.
And it's important because that type of miscarriage often requires medical intervention to quote unquote complete the miscarriage. That's why it's important to make that distinction.
A missed miscarriage is what happens when there is a pregnancy and the embryo just stops developing, but the body has not recognized the loss. There is no symptoms, there is no bleeding, there is no cramping. This is usually diagnosed at the time of an ultrasound. The patient comes in for a routine ultrasound thinking everything is going to be okay, and then we find out that there's no longer a heartbeat present and that the fetus or the embryo has stopped developing. When there is a missed miscarriage, it's important to obviously diagnose it and recognize it and then help you with active management to help pass the pregnancy, which we're going to talk about in detail in part 2.
Another term that we sometimes use, but less commonly, I would say actually, is a threatened miscarriage. This is a situation where somebody knows that they're pregnant, they have bleeding, they may experience some pelvic cramping, but there's no pregnancy tissue that passes. And so they may reach out to their healthcare provider, have an ultrasound done, and then it's found that there's still a heartbeat and the pregnancy is progressing on ultrasound in the way that we expect. This is not a miscarriage, really, per se. It's just that it was threatened to be a miscarriage, but it turns out that it's not. These pregnancies typically continue with no further issues.
Another type of miscarriage, which is not very common, thankfully, is called septic miscarriages. And what that means is that a miscarriage has happened and for some reason there is an overwhelming infection, usually that affects not just the uterus, but the whole body. People can have severe fever, they can have hypotension, and if it's very serious and untreated, it can actually be life-threatening.
Another term that's commonly used is recurrent miscarriages. This is a term that's used for individuals who have had multiple miscarriages. Everybody will define recurrent miscarriages a little bit differently. So what I mean by that is that different textbooks, different societies, all have slightly different definitions on what recurrent pregnancy loss or what recurrent miscarriages actually means. When we look at the definitions, generally they will say that this means 2 or 3 miscarriages. Sometimes they'll include that they need to be consecutive, sometimes not. And the reason why we make this distinction, or the reason why we give it this specific name or a specific diagnosis, is that this may indicate some sort of underlying medical issues that could require further investigation and treatment. Now, recurrent miscarriages or recurrent pregnancy loss is a huge topic in and of itself, and this is going to be a separate topic for a future podcast episode. Trust me, I'm working on it, and it is going to come.
The risk of miscarriage really varies a lot by age and gestational age. For example, 80% of miscarriages occur in the first trimester, but most of them happen between 7 to 8 weeks of pregnancy.
At around 4 to 5 weeks of pregnancy, or thereabout the time of the first miss period, the miscarriage rate is actually around 25 to 30%, because during this time, some miscarriages can happen before a woman even realizes she's pregnant. Sometimes the period may come at the regular time, or it may just be mistaken for a late period. There's a lot of miscarriages that are happening that are probably never clinically recognized.
By week 6 to 7 of pregnancy, the risk of miscarriage drops further to about 10 to 15%. At this stage, that's when a heartbeat can be noted on ultrasound, and the presence of a heartbeat is a positive sign for pregnancy viability. So once a heartbeat is noted on ultrasound, the risk of miscarriage drops even more to about 5 to 10%.
By week 8 to 9, the miscarriage rate drops even further to about 5%. As the pregnancy progresses, risk of miscarriage continues to decrease. For example, by 10 to 12 weeks, the miscarriage rate is less than 2 to 3%, and after 12 weeks, the risk of miscarriage is less than 1%.
Hopefully this can give you some reassurance. I know the first trimester can be really stressful. As we mentioned, you can have symptoms that come and go, and you are not able to feel the baby move yet. But as you can tell from the statistics, if there is a heartbeat present on ultrasound at about 8 to 9 weeks, and again at 10 to 12 weeks, the risk of miscarriage does decrease significantly.
Miscarriages can happen for a variety of reasons, and it's important before we go through it to point out that many of them are beyond anyone's control. And many of them are not due to something that you did or something that you didn't do. So let's go through some of the most common causes of miscarriage.
The most common cause of miscarriages is genetic factors. For example, genetic abnormalities are the leading cause of miscarriages, accounting for more than 50% of the cases. These genetic abnormalities happen during fertilization when the egg and the sperm join and two sets of chromosomes come together. Chromosomes are these tiny structures inside the cells that carry the genes. Genes determine a person's physical attributes and assign sex, hair, eye color, body type, etc. Sometimes when fertilization happens, these chromosomes can be rearranged in the wrong way so that genes are in different places where they're supposed to be, and this will lead to an embryo implanting and starting the development process, but not completing the fetal development because of the problem with chromosome rearrangement in terms of numbers and position of the chromosomes. These things are random and they're unpredictable errors in the embryo's genetic code, which makes it non-viable. The chances of chromosomal abnormalities is highly associated with the age of the egg where the embryo came from.
Now, over the past few years, you can actually test the genetics of pregnancy tissue. So if somebody has a miscarriage, you can potentially do genetic testing on it to determine whether genetics was the cause for the miscarriage. There's two different tests that are out there that are available right now on the market. In one test, it's a tissue test. You have to actually collect the pregnancy tissue, and then it can be sent for genetic testing, specifically looking at the chromosomes. There's a newer test that is called non-invasive product of conception testing, and it's a blood test that can look for fetal DNA inside the bloodstream of the person carrying the pregnancy. Now, although a blood test may seem easier, one important caveat is that this person cannot have had any bleeding. So really, being able to do this blood test is only applicable if somebody has a missed miscarriage and they proceed with the blood work before any bleeding has occurred. Testing of tissue, again, involves the collection of tissue, which can be really challenging as a miscarriage is happening because there can be a lot of bleeding, a lot of blood clots, and it can be really difficult to distinguish what is actually fetal tissue versus what is blood clot. And again, the collecting of it can be kind of tricky. Now, these tests are not covered under OHIP, and as of the summer of 2024, the cost ranges about $600 to be able to do the testing. If somebody's interested in doing the testing, there is a specific kit, especially for the tissue testing, that helps you collect the pregnancy tissue and it gets sent out. We do have the kits available here at Markham Fertility Center, or you can also access them on the company's website. Now, the challenge with this test is interpreting the results after. When you do this testing, there's three possibilities. One is that the tissue can come back genetically normal. Another option is it can come back genetically abnormal. And the third option is that it may come back inconclusive because there was not enough fetal tissue or fetal DNA, or they weren't able to extract the fetal DNA from the tissue because of the collection, etc. And that actually happens not uncommonly, unfortunately. If the tissue comes back as genetically abnormal, then we can say that this was the most likely cause for the miscarriage. So the pregnancy was genetically abnormal, and that's why the miscarriage happened. Now, it does not necessarily help you predict your risk of miscarriage in the future, because it would be the same as your risk related to whatever age the person providing the egg is. If the tissue comes back genetically normal, then that may merit a discussion with your physician about further testing to look for other reasons why somebody may have miscarriages. And that is probably where the testing is most helpful, or where it can provide you with next steps. Because at the end of the day, this test can't reverse, can't change what happened. But really, the goal is to try and figure out what we can learn from this test to help you in the future pregnancy to reduce the risk of miscarriage in the future.
In my experience with my patients, I find that doing the process of conception testing and having it come back abnormal can be very good for emotional closure, because sometimes even when I tell them it is not your fault and it's most likely related to chromosomal abnormalities, it is hard to believe it when it comes to you. So I find that sometimes doing the testing, when it comes back abnormal, it can be very reassuring from the point of view that it's definitely nothing I could have done because the embryo was not viable to begin with. Like you mentioned, if it comes back normal, then that does open up a kind of worm and a discussion with the fertility specialist as to what we're going to do next. Here at Market Fertility Center, we have a genetics department that can help you coordinate the process of conception testing. If that's something that you're interested in, you can tell your care team, your nurse, your physician, or your genetics counselor, and we can arrange to have the kit sent to you, or you can pick it up from the clinic, and we can do the testing accordingly.
Genetic factors often go hand in hand with age, specifically the age of the egg provider or the age of the egg. The reason for this is because we know that women are born with all the eggs they're ever going to have in their lifetime. A woman, let's say at the age of 35, those eggs that are in her ovary have been there for these 35 years, and we know they accumulate little bits of genetic damage over time. As women get older, the proportion of genetically normal eggs will decrease as the proportion of genetically abnormal eggs increases. For instance, the situation, again, where you have a 35-year-old woman who conceives spontaneously, the chance that that egg is starting genetically abnormal is higher than if a woman's conceived spontaneously, let's say at the age of 30. And so that is why specifically the age of the egg is so intimately linked to risk of miscarriage. Generally speaking, we sort of say women over the age of 35 have a higher risk of miscarriage because of this increased likelihood of chromosomal abnormalities in the eggs. Looking at age and risk of miscarriage, but a woman under the age of 30, the risk of miscarriage is relatively low, and it's only about 10 to 12%.
30 to 34 years old, this risk is going to increase to about 12 to 15%, and it's going to go up even more in the 35 to 39-year-old range, where the risk continues to increase at approximately 15 to 20%.
Now, the risk does not continue increasing in a linear fashion. So by the time a woman is between the ages of 40 and 44, that risk can go all the way up to over 30, up to 40% even. And over 45 years of age, the risk can be 50% or even higher.
Because of the increased risks of chromosomal abnormalities and miscarriage associated with age, this is why we recommend pre-implantation genetic testing, where you're doing IVF for women who are older. And you can listen to episode 30, where we talk about PGT in more detail.
On episode 22, we had a wonderful discussion about egg freezing. Now, it might seem a little weird to mention egg freezing in this moment. However, we spent a lot of time talking about eggs and egg number and egg quality with aging. And so it actually does go hand in hand with this discussion around age and genetic issues. And so that might be of interest to some of you.
Now, just stepping aside from genetic abnormalities, which again is one of the most common causes of miscarriages, there are other causes of miscarriages as well, such as certain health conditions. For example, uncontrolled diabetes, uncontrolled thyroid disease, certain autoimmune conditions like lupus, antiphospholipid antibody syndrome. So it is important to have these conditions managed and under control prior to undergoing a pregnancy, to decrease the risk of miscarriages and pregnancy complications.
Along those lines, some of the medications that people take for some of these conditions may also increase risk of miscarriage or increase risk of pregnancy complications. So for anyone who's planning a pregnancy or thinking about pregnancy, it's important to share that information with your whole care team, with all the care providers, so that they can optimize the medical conditions and the medications for pregnancy.
Besides health conditions, there's also some uterine anomalies that can lead to miscarriages. For example, large uterine septum. There is some controversy about whether or not this causes a miscarriage or not. Having fibroids, specifically submucosal fibroids that are growing inside the uterus. And we actually have an episode on this topic. That's episode 28.
Another factor that we consider when we're talking to a patient, let's say, for why they may have had a miscarriage, is lifestyle factors. And so this is a big umbrella term. that includes lifestyle choices such as smoking cigarettes or vaping, excessive alcohol consumption, recreational drug use like marijuana, we know that these things can potentially contribute to an increased risk of miscarriage. In episodes 6 and 7, we covered lifestyle factors for women and for men. And we talked about marijuana's impact on fertility in episode 18. It's important to point out that everyday activities, so things like exercise, sexual intercourse, do not cause miscarriage. Another big category of things that we look at is environmental factors. This could be things like exposure to certain environmental toxins. Let's say if somebody has a particular job, certain chemicals from exposure from the workplace, radiation as well. We know radiation exposure can increase miscarriage risk. And so when patients are pregnant, we do advise them to avoid exposure to these hazards as much as possible. And then in cases where this is an important part of their work, to let their employer know as soon as they are pregnant so that the employer can make accommodations as needed.
We've talked a lot about the different causes of miscarriage, and I think it's important to know that in the majority of miscarriages, we don't know what the cause is. Unless we're specifically doing products of conception testing, which have we mentioned, it is expensive, so not everyone does it for good reason. Most of the time, we don't know what caused a miscarriage. Now, that doesn't mean that we cannot help you achieve a term pregnancy. Once you're able to get pregnant again, most people that have miscarriages do go on to have a healthy term pregnancy subsequently. And I think it's important to also talk about things that do not cause a miscarriage, because it's very common when people have a miscarriage to blame themselves and go through the mental checklist of everything that they have done and wonder if that was the reason for miscarriage. Having sexual intercourse does not cause a miscarriage. Stress is not a cause of miscarriage. Doing exercise is not a cause of miscarriage. Also, lifting heavy things, picking up your children, moving furniture, going up the stairs, going down the stairs, those things are not the cause of miscarriages.
Other things that do not cause miscarriage, missing one dose of your prenatal vitamin. That's something that I hear a lot from patients. That absolutely does not mean that that's why you had a miscarriage or increasing risk of miscarriage. Having a glass of alcohol before you knew that you were pregnant. For the record, lots of people do this, especially outside of the fertility treatment little bubble that we're sometimes in, where you might not know that you're pregnant, you might have a glass or two of alcohol. That is not going to lead to miscarriage or be a problem, and it's much more common than people think.
Also, there are no foods that cause a miscarriage. We do talk in pregnancy about not eating things that are raw or unpasteurized or deli meats. But even if you ate these things, unless you actually had an overt infection with listeria, which is very rare, just the fact that you ate them without an infection would not be a cause of a miscarriage.
The bottom line is that the vast majority of miscarriages have nothing to do with something that you did or something that you didn't do.
And tell that to your friends and your relatives who are trying to give you unsolicited advice about why you might have had a miscarriage. Yes. Nothing to do with anything that you did and didn't do. And you can send them this podcast episode if they don't believe you.
Mm-hmm. We should make a bumper sticker.
I hope that you found this discussion helpful, that you had some good knowledge and understanding of the types of miscarriages and the causes of miscarriage. And if you've had a miscarriage, please know that you're not alone. It is very common and that it is absolutely not your fault. One thing that we didn't cover here is the management of a miscarriage. And we're going to have another episode just to talk about that, because this is a complex topic. There is multiple options, and we want to make sure that we spend quite a bit of time going into those details. So stay tuned for the next episode.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast, or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.